All hear me. I hope you're all doing well. We would like to welcome you to our session today. It's our oxygen therapy and critical care, the case-based series. A few housekeeping items before we begin the session. We will be using the chat function for question and answer at the bottom of the screen. Please send all your questions through the chat and also feel free to introduce yourself. If you have any IT issues, you can send a message through the chat. And also remember this session is being recorded and your attendance is the consent to be recorded. If you have any audio problem, if you can't hear the music, you can try any of these tips. On your phone, tap to the speakers at the top left or try using the headphones. And if you fail, try to log out and log back in again. My name is Kevin Raphael. I work with Assist International. I will be assisting with posting the links to the chat. And also I would like to inform you that this session is brought to you by a collaboration between Assist International and Stanford University Division of Global Anesthesia. Also the University of New Mexico Health Sciences, together with the Project Echo Institute at New Mexico. After sharing those, I would like to welcome Dr. Ananya, the Hub Director for this series, so that he can introduce the other panelists and continue with the session. Dr. Ananya, please welcome.
Thank you, Kevin, for a good housekeeping. So, as you know, today we are going to be having the fifth session on oxygen therapy and critical care management. Today we have two panelists with us, Dr. Jonathan and Dr. Brahani from Addis Ababa University. Those are anesthesiology and critical care physicians. So I will give them a chance to say a word about themselves, to introduce themselves. So can Jonathan please introduce yourself to our participants?
Okay. Thank you, Dr. Ananya. As Dr. Ananya mentioned, working in Tukrambesas, physicians of anesthesiology and critical care specialists, and I'm happy to join you on our today's session. Thank you very much.
Dr. Brahani, can you?
Okay, thank you, Dr. Anna, and the rest of the audiences. And I'm Brahana, anesthesiologist from Addis Ababa University. I've been graduated around 2 years back, and my interest is in critical care. And I'm really happy to join this session series. Thank you.
Thank you, panelists, for joining us, and thank you, participants, and all those who are supporting us from ECHO and Assist International. So, as I said previously, today we'll be discussing about the fifth part of our session, which the topic will be critical care outside the ICU and a rapid response system. So, throughout our discussion, we will be based on the case, as usual, and the case is a 50-year-old male patient with a history of coronary artery disease, hypertension, and type 2 DM, who is just admitted to the inpatient ward 3 days ago after being diagnosed with COVID-19. So, with this case in mind, we have the following practice change objective. So by the end of the session, we'll be able to define the critical care and continuous care of critically ill patients, or we say critical care continuum. And we'll be able to, redefine SPO2 goals for oxygen therapy. And we will be looking to different scoring systems like SOFA, MUSE, and CSI systems. And we'll outline the life-threatening signs and symptoms indicating time critical care. So, critical care is not only just provision of a care, but there is a component of also time. So if we are not timely addressing patient's conditions, the patient will deteriorate, there will be high morbidity and mortality. So we have to know what are these warning signs or life-threatening signs. And to handle this, we need to have, a key personnel that offer time critical care. So we'll identify who those key personnel will be to give rapid response. And, you know, there is a rapid response system policy or team, and this we can review or create our own after, you know, this discussion. And we are expected to practice and simulate scenarios to identify gaps and areas in regards to critical care management in our setup. So these are the basic practice change objectives we have today, and our discussion will evolve through these concepts. Now, to start with, we need to define, you know, critical care, okay? So critical care, we have to think of, you know, as a continuum. It's not something static, okay? So to help us, you know, in discussing, let's see your participation in the chat box as usual. So I will be forwarding a question, okay? So which of the following are considered critical patient care? So we have 5 choices. 1, early recognition, assessment and decision-making for deteriorating patient. 2, rapid and timely intervention for patients at risk of clinical decline. 3, identification of clinical warning signs prior to cardiac arrest or respiratory arrest. 4, providing expert assistance in response to concerns for a patient's status. And 5, all of the above. So take a few seconds or a minute to answer these questions on the chat box, and it will open our discussion. So I can see from Tarakan 5, Swallow Lago 5, okay. Samacho all, okay. The journey also said all. Fagadu said all. Yeah, I'm also receiving all from Aptamu. Daniel Tadas also said all of them are critical care. UL Jornet also all. Stibel Mangustu all. So many of our participants are saying all. Is there anyone who has any different opinion here? Different answer, different choice? Yeah, for the sake of you know, keeping attendance as well, those of you who are joining from the same device, it would be very helpful for us to write on a chat box that you are this many from this same device, okay? In the chat box, please try to write that. So I think most of you said all of the above, and I agree with all of you that all these choices are, you know, considered as critical patient care, because critical patient care is not just a care in the ICU, but it starts from, you know, pre-hospital, then in the hospital, pre-ICU, ICU, and post-ICU, and it involves early recognition, assessment, and then decision-making and intervention to help deteriorating patients or high-risk patients from declining or developing, you know, incidents like cardiac arrest, respiratory arrest, or other organ failure, okay? So we also need to provide expert assistance anywhere if there is a concern, okay? It could be, it should not be only health professional concern, but patient's concern or patient's attendant concern of a critical illness. Then if you go support, whether it's ICU or outside of ICU, we have to consider it as critical care. And always understand that critical ill patients will not have, you know, a full-blown sign symptom at the time, but there are always some warning sign ahead of time. And if you pick at that stage, then treatment will be easy and outcome will be also improved, okay? Yeah, so regarding, critical care management, if you are in a Western setup, then there is a so-called team for CPR, or you call them code blue, and whenever there is, cardiac arrest and so on, you call them. But in our setup, we don't have this thing standby. But in Western setups, other than calling this team of expertise to assist in cardiopulmonary arrest, they have also a team which address critically sick patients in the ward or emergency setup, or in the hospital, or even pre-hospital. And these are, a rapid response team. And this kind of things really help, in preventing severe disease that leads to mortality and morbidity. So all of you have agreed that, in our previous questions, that starting from, assessment, decision-making, early recognition, intervention, this is termed as, critical care. So maybe to strengthen further our discussion, I will have my second question here. So how would you define critical care? Okay, where does critical care occur, and how does critical care differ from intensive care? So take the next 2 minutes to write something regarding this, okay? So the first thing is, how do you understand critical care? How do you define it? And where is it occurring, okay? Then, is there any difference between critical care and intensive care? So you can try, 3 of them or 1 of them. Yeah. You may not be expected, to write a long sentence, but just in a short, how do you, define critical care, and where is critical care going to be given? Okay, where does it occur? And is there any difference with intensive care? Okay, I'm getting participation here. It is a medical care which is provided for people who have life-threatening illness or injury, and it's mainly given at the ICU. Okay, so yeah, very good. Yeah, it's something to be given for life-threatening illness or injury, and mainly it's given at the ICU. So when I read this mainly given at the ICU, so it might tell me that it can also be given outside of the ICU. So, but most of the time, the commonest what we know is to be given in the ICU, and there is a life-threatening illness. That's good. Yoel said the difference between, intensive care and critical care could be the places where they are given. Okay, so maybe it's good if Yoel, if you can specifically maybe mention which one is being given. So Tarakan said it is a care given to critically ill patients and started at the emergency department. So Tarakan is trying to describe that critical care is a continuum, it's a process. So it can start in case of hospital at the emergency department, and it continues up to a higher level of care. And it's not something just to be delivered only at ICU, okay? You will also try to mention, intensive care is given in the ICU and critical care can be given outside the ICU. So this also, is trying to tell us critical care management is not something confined in the ICU alone. Maybe our understanding practice previously could be all critical care is to be delivered in the ICU, but now, it seems like we all are understanding that critical care can be given outside of the ICU, and it starts even before patient transfer to critical care. Yeah, very good participation from our participants. Okay, so one more, Samacho said it is early recognition of life-threatening incident, managing with available material where, and it's given at ICU. Excellent. There is a component of, resource limitation. So even if there is a resource limitation, with whatever available, treating critical care or providing critical care, whether it's in the ICU or outside, is kind of mandatory. So there's something Samacho is trying to tell us. I think it's good. So let me maybe invite one of my panelists, Dr. Brahani, to say what he thinks regarding, critical care and the concepts. Dr. Brahani.
Okay, thank you, Dr. Ananya and the audiences. So the participants, most of you have explained it well. So critical care is, as it was being said before, so it is a continuum of care in the caring of critical sick patients. It even maybe started before the emergency. So for practicality, critical care, the continuum of critical, of course, it's a continuous, it's a continuum of care, but for practicality, we can divide critical care into like four or more areas. Like critical care can be given in the pre-hospital and pre-ICU plus pre-hospital areas. Like it can be given as a scene in some traumas. It can be given as battlefields. It can also be given in the imaging units. It can be given during transportation in the ambulances. It can also be done in the public. We can, for example, teach public in preventing critical illnesses like stroke, MI, or hypertension. Critical care can also be given in pre-ICU in hospital setting, like in emergency department, in the wards, be it medical or surgical ward. Critical care can also be given in the ICU. And critical care is not limited up to the ICU, but also it goes beyond. So it's also given in the post-ICU. So after discharge, we have to still caring for the critical sick patients. And it can also be given in the home after discharge, in rehabilitation centers and in post-ICU clinics. So this is because the outcome of critical sick patients is not only depend on the care of the patient in the ICU, but it depends on all of these areas. So it depends, the outcome depends in the pre-hospital, the outcome also depends in the hospital, in the ICU, and of course, in the post-ICU at home and at rehabilitation centers. So when we say critical care, it's a continuum of care, and it can be done in different areas. It could be pre-hospital, pre-ICU in hospital, in the ICU, and post-ICU after discharge. And but when we say intensive care, so it is specific to ICU. So among this continuum of critical care, so intensive care is, we can say, a subset of the critical care. So intensive care is So the care given to critically ill patients in ICU, in the intensive treatment unit or intensive care unit. So I think this is the difference between critical care and intensive care. But honestly, many people may be seen using these terms interchangeably. But of course, they are different.
Yeah, thank you. Thank you, Dr. Brahan. It was a nice explanation of what critical care is and where it can occur. And also the difference between intensive care. As you said, you know, many people may say critical care and intensive care are same, or they can use interchangeably. So as far as the term is concerned, it's not a problem to use them interchangeably, but you know, the idea is we have to understand that critical care is not something confined just in the ICU, but it is something to be given outside of hospital or in hospital or away from the ICU as well. And it's a continuum process. The illness is continuous, so the care needs to be also continuous, and multidisciplinary team are acting there. And the goal is, you know, to save patients earlier by intervention, by giving intervention as early as possible. And recognizing critically patients is also something very important. Okay, so we'll further strengthen, you know, our understanding when we are seeing also the case. So let me give you now the case example. So let's say the setting now, you are working in a rural hospital, and the nearest hospital with an ICU is just 90 miles away by ambulance. But the roads are closed today due to weather issues. So your patient is in a medical ward, and he's a 55 years old male with a history of coronary artery disease, hypertension, type 2D, admitted to the inpatient ward 3 days ago with COVID-19. His chief complaint is shortness of breath, and on round in the morning you noticed he was slightly tachypneic, respiratory rate is 27 breaths per minute, but still speaking in full sentences. He requires oxygen by nasal prongs at 3 liters per minute. He has a few crackles on the lung exam. His exam is otherwise unremarkable, okay? So if you see the vital sign, then his respiratory rate is 27 breaths per minute, temperature is at 7.9 degrees Celsius, heart rate is 95 beats per minute, and blood pressure is 107/59, and saturation of oxygen is 92%. Now, what is your interpretation of the patient's vital sign and physical exam? So from, you know, vital sign and physical exam, what do you pick? What's your interpretation? So you can write it in the chat box. So this is the same case we gave you at the beginning of this session, and is a 54-year-old man with comorbid condition in COVID-19, admitted in the ward and is being monitored. Okay, so your vital signs are like the ones displayed on the screen, and physical exam consists of, you know, few crackles on the lung, and is receiving oxygen by nasal prong at 3 liters per minute. So how do you interpret the vital signs like the respiratory, temperature, heart rate? Are they normal or abnormal? So you can tell us that, you know. Okay. Okay. participants. So what do you think is the respiratory rate in tachypneic or normal? And temperature, is it normal or normal? Heart rate? Yeah. Very good. So from Fukadu, this patient is tachypneic despite on 3 liters per minute, and he needs escalation of oxygen. That's great, excellent. So you have witnessed that, his respiratory rate is increased while on oxygen support. So you want to escalate, oxygen therapy. So that's a part of, early recognition of critical illness or pathology, and make a decision, and then you started, intervention. So the journey also said tachypneic and also febrile. Okay, so yeah, the normal body temperature average could be 37, but it could be in the range of 6.5, 37.5. Now here we said 37.9. So he's febrile, so that means there is something to do here. So again, you picked, you recognize there is an ongoing problem. Okay, very good. Who else? Yeah, Samacho. Issue is, respiratory rates increased, oxygen is low. So he has low-grade fever, but blood pressure and heart rates seemingly normal. So this may not be, patient in shock or some sort of organ failure and the like. So it doesn't mean that he may not be, critically sick. But as you said, it may not be said that is a patient to be admitted immediately to the ICU, but, he has some warning sign occurring. So saturation is dropping, respiratory rate is increasing, and if not timely intervened or be prepared to worst thing to come, then you may, end up in severe complication. Also, we have a participation from EUL. A patient is obviously tachypneic and a higher heart rate also, even though it's a normal range, but it's relatively higher. And for someone who has coronary arterial disease, this could be very dangerous. I agree with you, because it can increase, the demand. And with coronary artery disease, we know that supply to the myocardium is compromised, and whenever the demand increases, may predispose the patient to myocardial ischemia, later to infarction. And also it said patient is desaturating despite oxygen support, like 3 liters per minute. So yeah, there may be, dilution may not be actually 100%, but with 3 liters per minute, receiving something, 32 or around there FO2, but still 92% is desaturation, obvious. So his lung condition is worsening. That means tells you the lung condition is worsening, and there is something to be done. And patient's febrile. So you want to, further investigate. So I agree with you. You want to further investigate as well as intervene, manage the patient. Okay. So also we heard from, name is not seen, from someone using Techno. So current vital sign is normal, but according to age and COVID, we must think other investigation like X-ray, CBC. Yeah, so you kind of picked, there is some problem, but the severity may differ, But even though we might not have seen, immediate organ failure or something very serious here, the patient is showing some warning sign and a sign of deterioration, and early intervention is important. It could be, therapeutic, as I said, increasing oxygen support, mobilizing the patient to a higher level of care, or doing some further investigation is something to intervene at this time. So yes, and follow-up needs to be done from Subalo. And a lot of participation now. Yeah, so we have to look for sepsis. We have to use SOFA to diagnose. So diagnosis, early assessment is something we can see from this discussion. So from the vital sign, we're looking that this patient's not doing well despite our support, and that he needs further management. Okay. For your further reading, when you go to the Learning Resource Center, you can find a link by clicking on this question. There is a, something here, it says click. So if you go to the Learning Resource Center, found this presentation and press click, you'll find, some description regarding this issue for your further understanding, okay? So now I think critical care recognition, intervention seems to be becoming more clear, but we'll see further how we are doing things. So our other practice change action items, to understand SpO2 goal for oxygen therapy. So to what level, to what target we want our SpO2 level reach when we're administering oxygen, okay? So now let me update on the same patient case. So despite, 3 liters per minute of oxygen by nasal cannula, 2 hours later, let's say the patient's SpO2 decreased to 6%. When you arrive, he appears to be more tachypneic, is working harder to breathe, and he can only speak 2 to 3 words at a time. So now, patients really desaturating, is showing severe manifestation of respiratory failure, hard work to breathe, tachypneic, and even he cannot speak words, okay? Now, at this interface, I would like to ask you, what is the goal SpO2 in this adult male patient? So if you want to treat, of course, you want to treat the hypoxemia or hypoxia he's having, and if you have to treat, what will be your goal? And what intervention should be taken for this patient? So yeah, Emmanuel said, my goal will be more than 92%. Okay. So more than 92 is acceptable, but it's a bit wide, When you say more than 92, I may understand that as 92 to 100%. It's good to have it in a range, right? So ideally above 95, I thought you said 94 to 98, okay? Also, it's good if you tell us also what intervention you'd like to take for this patient at this moment, okay? Yeah, Subalo 92 to 96. Adisu said more than 94%. And also the intervention should be to escalate to non-rebreather mask, okay? He's already on a nasal cannula and desaturating to 86%. So you recommend to escalate further with the oxygen device and changes to face mask. Yeah, 94 to 96, okay. With face mask, CPAP, intubation. So serial of supports has been described from face masks and progressively to non-invasive ventilation and invasive ventilation. Okay. I'm seeing above 94%. Also, I'm seeing on a chat box, ideally, my goal is to keep saturation above 92, and my intervention would be just to increase the flow, nasal flow from 3 liters to 5 liters per minute. So all are, acceptable answers from, our participants. So the only difference is, the range and, the intervention, the extent of intervention. So yes, so from Fakadu, increase oxygen to 5 liters until saturation is kept between 92 to 96. That means this is the goal oxygen saturation. And if this is not helping, then change it to a simple face mask. Then can be supported with non-invasive ventilation. So it's good that the last non-invasive ventilation because of work of breathing. Okay. So his work of breathing is already harder. He has some impending respiratory failure, so ventilatory support might be needed as well. Yeah, that's very good from our participants. Very important points as raised. So maybe let me invite, my panelists, Dr. Jonathan. What do you think, Dr. Jonathan? What intervention should be given to this patient, and what should be the goal? Is there any recommendation you can come up with?
Okay, thank you, Ananya, and thank you the other participant as well. There was a good answers from the participants as well, especially when you are treating hypoxia or any forms of oxygen delivery. We need to target, especially oxygen toxicity should not be forgotten. That means oxygen is not a harmless drug, or it has to be considered as a toxic drug. So we shouldn't target a higher saturation, especially for medically patients, especially who don't have indoor organ damage, especially MI or stroke patients, we might not need to go saturation above 96%, especially as a target. But when patients, especially if you are delivering oxygen, we need to target at least saturation of 93 and above. Usually it is a target recommendation, but we shouldn't go high above of 96%. But specifically when you are coming to patients like our cases or patients who have features of stroke, we might not need to go lower down, like saturation of 90 to 92% might be a good or lower target in order to decrease the risk of oxygen toxicity. But when you are delivering oxygen, definitely, especially our target saturation should not be a higher range. We tend to go for 93 and above % saturation of oxygen is a recommended one, but we shouldn't go above 96% because oxygen delivery has its own side effects, like it may affect our need for nurse caring, especially when we are targeting appropriate amount of saturation. It requires a good or close monitoring from the nurses, especially from patient bedsides. It might affect our patients' mobility, patients also discomfort, especially when you are using different forms of oxygen delivery device. It might increase the risk of patients' discomfort or throat, sore throat or dryness of the buccal mucosa. These are the major side effects, and also on top of the oxygen toxicity effect. So we shouldn't always forget when we are administering oxygen for our patients. The toxicity effect should not be forgotten as an input for this one.
Yeah, thank you, Dr. Ananya. So definitely, we have to have a range. On previous discussions also in COVID-19 patients, we said our goal will be 92 to 96%, but it's not for all patients. So you have to remember there is a difference for pregnant ladies or patients with other comorbidities like COPD and so on. So taking that, this patient may not have, didn't have any COPD, and is just patient hypertension type 2D. His SAT was 92, now dropping to 86, and we want to keep something higher than 92, but not beyond 96, as Dr. Jonathan said. So, Dr. Jonathan, if you find this patient maybe in your ward, I know that you are, managing COVID patients in one of our hospital, like Ras Destadam, the hospital in Addis. So how would you, intervene at this point now? Just escalate oxygen therapy, or you go even further with the intervention?
Yeah, exactly. This patient clinical deterioration, if you can see, that become febrile, especially the work of breathing or the hypoxemia or the recorded saturation is becoming as 86%, and also he's becoming tachypneic, like respiratory reaching to the level of 32, and also becoming tachycardic. This is an impending or early clinical signs that this patient's clinical condition is deteriorating. So we need to have some intervention, especially the hypoxemia is worsening. I think we need to go for escalation of the oxygen delivery, especially with nasal bronchi only on 3 liters. We might need to escalate it higher up based on the patient's response. And if it's not responding, especially with nasal bronchi, we may reach with the face mask reaching 5 and above liters of oxygen has to be delivered for this patient as well. At least oxygen saturation must be increased for our patient.
Yeah, exactly. So yeah, I agree with you as well. At this point in time, oxygen therapy needs to be escalated, and preparation has to be made as well for transport of this patient to ICU and escalation of care. As you know, this patient is going to progress to more severe form of the disease with full-blown respiratory failure, and definitely may need some form of invasive ventilation. So through this case, we understood that there is a need for recognizing a critical illness progression. So we need to assess them, carefully and closely. And after that, we have to come up with our intervention plan, and we have to know what our goal is. So the goal of oxygen therapy needs to be also known there. So let's update, patient's case now. Let's say when you, after escalating your oxygen therapy, so new vital signs are obtained for this patient, because, monitoring needs to be now very continuous and very close. So let's say while monitoring, you get the respiratory rate to be 32 breaths per minute, temperature now 39, heart rate 115, blood pressure from non-invasive measurement, H3 by 55, and saturation of oxygen 86, okay? So definitely all the vital signs are now deranged at this point. Now, to help you, to decide at this point in time, using different clinical scores is recommended, or it would be useful. It makes your management maybe, or your decision, or your, anticipation of progression of the disease or prognosis could be made easier by using different clinical scoring mechanism. Okay, so in the next two questions and few minutes, now we'll be able to understand what these scores are and what their use is. Before doing so, what do you think? Which of the following are possible differential diagnosis for signs and symptoms given? Okay, I have given you this, respiratory rate 32, temperature 39, heart rate 115, blood pressure H3 by 55, saturation 86%. And remembering, a patient's case scenario and newly developed signs and symptoms, what do you think could be possible differential diagnosis? Is it sepsis, SIRS, respiratory failure, ARDS, or all of them can be a differential diagnosis? So take a few minutes to participate in this question. So for the previous discussion, you can always find a link by entering the Learning Resource Center and by clicking on the blue box on a word, say click following the questions. Yeah, so we have participants saying all, okay, Daniel, Hussein, okay, Emmanuel, and so many of you. Zabidaru as well. So all, okay. Anyone with a different answer or idea regarding this? Yeah, as all of you are saying, from the signs and symptoms, we can say, okay, this patient might have, sepsis or SIDS, or there are signs symptoms suggestive of respiratory failure, or it could also be ARDS, So all of the above is a possibility. Now, if all this could be a differential diagnosis, then how can we differentiate which one is really the cause of this patient's clinical symptom or sign? So certain, clinical parameters can be used, or scoring parameters can be used. That's what we're going to discuss now. Even Emmanuel is saying QSOFA is a quick sequential organ failure assessment tool. And yeah, so this is going to be, our next question. So can QSOFA help us? What is it and when should it be used? Can it help us, in narrowing down the differential diagnosis, or it's just its purpose is something else? So do you have any, information regarding this? So the Jenny said QSOFA is something to be used at emergency level. Okay, good, very good. So yeah, so components are now here mentioned. Components of QSOFA could be respiratory rate, mental status change, and systolic blood pressure. Okay, so by looking into these components and scoring, will tell us what. So for what purpose are we using QSOFA? Is something remaining? So yeah, UL said to assess patient outcome and prognosis, okay? It can be done at bedside, and its main purpose is for assessing patient outcome and prognosis, and may not be for a diagnostic purpose, okay? Yeah, so Dr. Brahane, if you are with us, do you use QSOFA frequently? And if so, what are the components? I mean, some of our participants have mentioned the components. And when should it be used actually? Can it be used for diagnosis purpose, or it's just for a prognosis?
Okay, thank you, Dr. Ananya. So as most of the participants said, QSOFA is a simple version of the SOFA score. So it has 3 components, 3 clinical parameters, including the respiratory rate. If respiratory rate is greater than or equals 22, then we will give a point of 1. And the other component of QSOFA is consciousness level. So decrease the GCS from the baseline by greater than or equals to 1. At least 1 is sufficient to give a point. Or if the patient was conscious, then so if the GCS is less than 15, then we'll give 1 point. And the other component is systolic blood pressure of less than or equals to 100. So this QSOFA quick sequential organ failure assessment is used in the outside ICU areas. It's not used in the ICU. So I sometimes use in the emergency. Otherwise, since I mostly work in the ICU, I don't use quick SOFA. I rather use SOFA. But SOFA has to be used outside the ICU. It can be used in the emergency. It can be used in the wards. And its main purpose is outcome indicator. So it's not a diagnostic tool. It's not a screening tool. Some people by mistake use quick SOFA for diagnosis purpose or for screening, but normally QSOFA is used as outcome predictor. The outcomes being hospital mortality, inpatient mortality, and the secondary outcome is increased length of stay in the ICU more than 3 or more than 3 days. So it is, of course, outcome predictor. For example, if the QSOFA score is 1 or 0, then the likelihood of hospital mortality is low. This patient has low risk of inpatient mortality. But if the QSOFA is greater than or equals to 2, means 2 and 3, then the inpatient mortality is high, and the risk of prolonged ICU stay, probably more than 3 days, is high as well. We can't use, it's not a good predictor in ICU, so we don't usually use QSOFA in ICU because the predictability of QSOFA is less than the SOFA. So in ICU, we use SOFA. And in patients, if we are using SOFA for patients who are admitted with infection-related causes or suspect patients who are having suspected infection, then if we need to diagnose if these patients are having sepsis or not, then we have to use SOFA instead of QSOFA. So QSOFA is just for outcome prediction. Otherwise, for diagnosis of sepsis, we have to use the SOFA score. And in ICU, SOFA score has a higher predictability than QSOFA. So I don't usually use QSOFA in ICU.
Yeah, thank you, Dr. Brahana. It was a very nice description of what QSOFA is and where it can be used and what's purpose and what limitation it has. And I think all of our participants got that message. So maybe looking into, patients' vital sign now, what do you think will be the QSOFA? I think there is maybe the mental status might not be mentioned here. So if the mental status deterioration is there, then what can we conclude from our QSOFA?
So at least he has 2. So he has 2 score. This means score of 2 and 3 is associated with high inpatient mortality. And the probability of prolonged ICU stay probably more than 3 days is high in this case.
Yeah, so and, by knowing this, it will help us, for decision making.
Yeah,
right?
if you need. Yeah, and if you need to assess for sepsis, so this is the outcome predictor, as we said. So if you need to really know if this patient is having sepsis or not, so we have to use SOFA score. Instead of the QSOFA, we have to use SOFA score. And then by that, we can know if this patient is really having sepsis or not.
Yeah, exactly. So, respiratory rate is higher. We know blood pressure systolic is low. Even though mental status is not mentioned here, we can see that the QSOFA is high and patients at high risk for bad outcomes. So that's something you could know, and it's something utilized outside of the ICU. So our today's topic is critical care outside of the ICU. So QSOFA has, this importance, and knowing its limitation is very good. So it's not something to be used for screening or diagnosis. So can we, shortly go to, the other two scores, so that to keep the time, to keep up with the time, maybe I will ask Dr. Brahani if you can also elaborate on the other scoring systems like the Muse and the CSI scoring system. Okay, maybe Dr. Brahani, are you with us? So maybe until he's joining, it's also possible for participants. What do you think would be this?
Sorry.
Course?
Okay, sorry. So I was muted. Sorry, Dr. Ananya. Okay. I think now you are hearing me. Yeah?
Yes, we are hearing you. Yes, you can continue.
Yeah, it was muted. So the other score we can use for this patient is modified early warning score. So this modified early warning score is a tool comprising of like clinical parameters, and the main purpose of this modified early warning score is to early detect patient deterioration in the ward. So some patients may deteriorate just without the clinic, without knowledge of the clinicians or without knowledge of the nurses. So if we use scores like this, or if we use tools like this, then we may early pick if the patient is deteriorating. So we can also calculate this modified early warning score. So this modified early warning score has a lot of parameters, and it may be difficult to remember all these parameters, but either we can post on the wards, or we can also use medical calculators. So for example, if the modified early warning score is greater than 5, or if a patient has a single score of +3, then this means these patients are requiring more frequent monitoring. They require more senior physicians. They need to be evaluated by more senior physicians, and at the same time they need more interventions, and they also need a higher level of care. And so probably we may need to admit these patients if these patients have the modified early warning score of greater than 5, or a single score of greater than 3, then we may need to transfer these patients into highly dependency unit or into the ICU. So this is the main use of the modified early warning score. So it's for to pick deterioration early.
Yeah, thank you, Dr. Brahana. As you said, I'm also displaying the modified early warning score, and its main purpose would be for clinical deterioration. And as you said, it has got multiple, components like the systolic blood pressure, heart rate, like, systolic blood pressure, if it is, above, like above 100 and so on, Euro score increase, or below 80, 70 Euro score increases in both directions. The same thing with heart rate. Like 51 to 100 could be 0, and anything else will increase the score. And as you say, when the score increases, and it shows us that there is a high risk of clinical deterioration, and we have to, immediately act upon on such kind of patients. So the mental status, temperature, blood pressure is something to be included. Okay. And if the score is 0, then there is, a 7.9% chance of ICU admission or days within 60 days. But if the score is higher, you can imagine how much the percentage of admission or days can be increased. So this is something to be used outside of your ICU. So having this score printed out and using it for assessing clinical deterioration is something, as a take-home message from here. So maybe if you go to the Learning Resource Center open this article, and if you see, it has got, when to use it, okay, and what are the pitfalls, okay, a list of things, and why are we using it is also expressed here, and the components are here. So I encourage you to look into this document and have a better understanding. And thank you for Dr. Brahana for explicit discussion of this, clinical parameter, clinical scoring method. Okay. So what about CSI score?
Probably to add one thing, Dr. Ananya here. So this modified early warning scores, they are specific for different patient groups. For example, for surgical patients, the use of this modified early warning score may be a bit different. For example, a score of 4 is enough to transfer such kind of patients into, for example, ICU. But for other medical patients, probably a score of 5 may be good to be used as a warning to transfer patients into ICU. And pregnant ladies and pediatrics have their own scoring system. So this modified early warning score is specific for patient groups, for different patient groups.
Yeah, thank you, Dr. Brahani. It's also be good if we can share also this early warning score on our Telegram channel, Eco Oxygen Therapy, so that everyone can print it out and use it for assessing, clinical deterioration. So can we say something about, CSI score and when should it be used? Dr. Brahana, okay, let me give you the chance.
Yeah, okay. Yeah, thank you. So this quick COVID-19 severity index score has to be used for any patient with COVID-19 admitted either in the emergency or in the ward. But the parameters we use, there are 3, and the parameters we use are like respiratory rate, pulse oximeter readings, and oxygen requirement. These are the parameters we use to calculate the quick COVID-19 severity index score. So, but these parameters has to be recorded within 4 hours since the patients were admitted into the emergency. So we'll take any low parameter which was recorded in 4 hours during the emergency admission. So then, depending on that, then we can know the risk of development of critical respiratory illness within the next 24 hours. Critical respiratory illness is defined by, for example, requirement of oxygen flow of greater than 10 liters per minute through low flow device, or the use of high flow nasal cannula, or the use of either invasive or non-invasive mechanical ventilation. So these are indicators for critical respiratory illness. So this quick COVID-19 severity index is used for COVID-19 patients to predict if these patients are going to develop severe or critical respiratory illness in the coming 24 hours. And of course, this score is used for patients who are initially using an oxygen flow of like less than 6 liters per minute. Otherwise, if patients were using flow of greater than 6 liters per minute from the outset, then they have to be excluded. We shouldn't use this scoring system. Thank you.
Yeah, thank you, Dr. Brahana. So we have seen, all the scoring system here. So they have their own use, and they have their own advantage in critical care outside of the ICU. And we have to utilize them for predicting or assessing clinical deterioration, or even to know, the outcome. Okay. So for diagnostic purpose and as a screening purpose, we have also other different modalities that can be used in ICU, and this should be different be differentiated with quick clinical scores. So if you have any question regarding the different scores we have discussed, as Dr. Brahani also described them very well. So if you have any question regarding them, you can write on the chat box. And yeah, you can write this in chat box now, or maybe later if you have a question, difficulty in accessing them or utilizing them, you can also post questions on our Telegram channel, which all of you are members by now. So while waiting for your questions, if there is any, we have to progress to the rest part of our discussion today. So, you know, as we started in the beginning, we have to understand critical care is a continuing process, and it can be given outside of the ICU. And when it's given outside of the ICU, do we need some system, especially for intervention after recognizing critical illness? Would there be specific individuals who need to be incorporated in the management? Would there be a need to have a team or a system? So this is something we need to discuss, right? So our practice change action item will be outlining of the life-threatening sign and symptom indicating patients' need for time-critical care. On the same patient, let me update this case. So the patient, let's say, suddenly loses consciousness and the vital signs are obtained, and respiratory rates 40 breaths per minute, temperature 39, heart rate 147, blood pressure is 63/25, and saturation is 66%, okay? So now for this patient, what vital sign or clinical exam finding require immediate intervention?
I have one question from Amanil, Dr. Ananya. He's saying like, which scoring system is superior?
Okay.
Shall I answer it before this question?
Yes, please.
Okay, so thank you, Amanil. I think it's important question. So normally there is no, we can't compare this scoring systems with superiority because their aim is different. So the aim of QSOFA is different from the aim of KIC COVID-19 severity index system is also different from the early modified warning score. I mean modified early warning score. So their aim is different. So for example, the aim of QSOFA is outcome prediction. Outcome means inpatient mortality and length of ICU stay. And the aim of modified early warning score is for picking early deterioration or picking deterioration early in the wards. And the aim of COVID-19 severity index system is used for COVID-19 patients and is to pick or to know, to predict the probability of development of critical illness or critical respiratory illness during the next 24 hours. So the aim is different. For example, in this patient is COVID-19 patient, so we can use all the scoring systems, especially if the patient is in a ward, so we can use 3 of the scoring systems. So we can't compare the superiority because their aim is different. So we can use more than 1 of these scores in a single patient.
Yeah, thank you, Dr. Brahani. Yes,
thank you.
I think it's well addressed for Emmanuel. And if you have further question or if you want further clarification, also can write it in chat box. So for sake of time as well, we have to go progress with our discussion. And I have given you, the updated information regarding this patient. And looking into, vital sign, which vital signs do you think require immediate intervention? So these are what we call, warning sign now. Before a patient develop a cardiac arrest, we are now seeing there are warning signs here. Which ones do you think need immediate intervention? So, yeah, oxygen saturation, all vital sign, the airways simultaneously, if possible, in a teamwork. Okay, so airway, I think, needs to be assessed as well, yes. Because patient has, sudden loss of consciousness, so airway can be lost at this point. Patient is significantly desaturating. Blood pressure is too low. You see heart rate is also high. Can see the respiratory rate. So all this needs an immediate intervention, right? Vasopressor support, intubation, right? Yeah. Any different idea? So airway first. So ABC of life. I think you want to go ABC of life. So patient already unconscious. So when you go with ABCD of life, you check for patient's responsiveness, look for airway patterns, how is breathing, okay? So in adults, if it's a sudden, loss of consciousness, maybe sick may come first, so you check for carotid pulse. But in patients COVID-19 who was hypoxemic, so probably it could be, if there is a cardiac arrest, it's going to be hypoxemic initially. So you may look into, airway, breathing, circulation, and immediately intervene to the patient. So I again recommend you, to go to the Learning Resource Center, find article associated with this question. But as most of you agree, obviously agree with some our participants, there is derangement in oxygen saturation, blood pressure, and also the rest of vital sign and consciousness level, which needs, immediate intervention. So which of the following intervention may be needed for this patient? Is it a high level of care, increased oxygen therapy, more frequent monitoring, ongoing resuscitation, airway management, or all of the above? Okay, quickly you can, yes, you will say all of the above. Or, okay, most of you said all. I think I missed someone saying, let me see. First, this patient must do immediate action for respiratory. Yeah, so now it's obvious that there is a respiratory compromisation. Immediate intervention should be given for respiratory. As you said, COVID-19, hypoxemic failure is highly common, so starts AB, CD of life, so oxygenation needs to be improved, okay? So, yeah, so all of them needs to be given at this point. So immediate resuscitation, immediate intervention, life-saving intervention. That means, airway management, increasing oxygen therapy, and continuing resuscitation. Okay, the blood pressure is too low, so you have to manage that as well with vasopressor and so. And while doing so, also you have to monitor your patient frequently, right? Is the patient condition changing to my management, my intervention? Then you have to think of as well transferring this to a higher level of care. If it's something in the ward, this patient is not going to continue his care in the ward. After resuscitation and stabilizing the patient, then the patient needs to be transferred to the ICU as well. So these are the interventions you are likely to do. Now let me just give you a poll question. It's just to know if your facility have a rapid response system for inpatients. So anyone in Ethiopia with a facility having a rapid response system, please. Yeah, I'm expecting, no from everyone, but who knows? Some of our institution might have a rapid response system developed recently. If there are people who have started this, please indicate it. It's going to be, a surprise for us, and it's a prize for you as well. Yeah, Daniel is telling us no. Yeah. So yeah, as far as I know, there is no any institution with a rapid response system. We don't have even code blue and so on. So have you experienced anything, Dr. Yonatan or Brahana, regarding the rapid response system in any hospital facility in Ethiopia?
Thank you, Dr. Ananya. So when I was in Millennium COVID-19 Center, so we actually organized the rapid response team. So consisting of one physician, one nurse, and one emergency physician. So one general practitioner, emergency physician, and one nurse from the ICU and one nurse from the ward actually. And the main function of this rapid response team was transferring patients who had collapsed in the ward to the ICU and doing CPR in the ICU, because the PPE we were using in the ward were not full PPE. So whenever there is a patient who had cardiac arrest in the ward, so this patient has to be transferred into the ICU immediately, and the CPR has to be done because the CPR in COVID-19 patients is, as all we know, is a result generating procedure. So the main function of this rapid response team was this, but I'm not sure if it's functional now. But we're trying to establish.
Dr. It was a very good experience. It's first of its kind, and it's something developed in association with COVID-19 pandemic. And when you say the Millennium Center for COVID treatment, and it's a new center. It's a big center, and it needs to have a rapid response system. It was good that you have tried, but as you said, we don't know if it's successful or not by now. So from initial phase, how was it? How was it activated? The rapid response team. Who was activating the rapid response team at the initial phase? I'm sure by now this may have phased out.
Sorry.
So, who was activating rapid response team in Millennium when you were trying to establish a rapid response system?
So if there is actually the main aim of this team was just to manage patients who had cardiac arrest in the wards, COVID-19 cardiac arrest in the wards. So if there is any cardiac arrest in the wards, so the nurses in the wards will call to the team in the ICU. Actually, it was not a permanent, that the members were not permanent. The members were not permanent, so one of the members has to be a duty nurse in the ICU. So if there is a patient who had cardiac arrest in the wards, then the nurses in the wards will call to the nurse in the ICU, and the nurse in the ICU will activate inform the other members, and they will go fast and pick the patient and transfer to the ICU, and they will do the cardiac arrest.
That means the triggers.
There was no patient. It was just theoretical, I can say. It was not practical.
Yes. So you mean now the trigger for calling rapid response team was cardiac arrest, not just clinical deterioration, right? So that means the rapid response team was almost acting as a code blue team, or a team to be called for cardiac arrest. So rapid response team could be a little bit different in concept with code blue team, as this team should not only be called for just cardiac arrest, but before cardiac arrest, this rapid response team needs to come and treat patients. Okay, so triggers should be some form of warning sign, like derangement in vital sign. Okay, could be one of the reasons to call a rapid response team. But it's good, Dr. Brahani, your experience in this kind of system. It's new for us in a low resource setting, but it is something to be developed. So it's good if we kind of support. There could be people joining us from Millennium COVID Center. So this could be a chance for them further to strengthen this rapid response team. And if they go to this learning resource centers, there are a lot of documents they can be using in order to strengthen or reestablish the rapid response team function. Okay, and the triggers should be early warning signs, just rather than cardiac arrest as well. So Dr. Brahani, really it gives us as an input for our next discussion, which will be what is the team involved in rapid response, and who are the personnel and what they are going to do. So this is going to be our practice change item. So coming back to our patient, we have seen that he has deteriorated significantly. And so what providers should respond to this patient? Okay, Dr. Brahani was mentioning some individuals, but what providers needs to respond to this patient now, to our case?
Maybe Dr. Ananya, I might add some point on this one, especially for rapid response teams, which is mainly, as we might classify it, like afferent and efferent parts, those who have responded. I think it might be some physicians or nurses could respond for the early warning calls for those patients, and these patients or the people who are going to respond might be physicians or nurses who have a special training in providing a critical care support for like in organ support, who are expert in resuscitating a patient, and also who might be expert in transporting that patient to higher institute, like in different setup, like respiratory therapists or physicians who have training in anesthesia and critical care, or those who have training in critical care, including nurse could be a respondent for the early call. That means the calls might be from anyone who have been as an activator or a triggerer, but the respondent might be the one who have a good clinical background in providing a critical care for the patient, would be a good respondent for rapid response system.
Yeah, so thank you, Dr. Jonathan. As you said, anyone with training to care for critically ill patients, be it nurses, physician, or critical care doctors, can be incorporated in different models. So, I'm seeing that on a chat box. Some have a rapid response team, like in Haramaya, it's like a MeCare. So please share us also your experience in the chat box, who the providers are there, or MeCare. Okay, so now with this COVID pandemic here and there, now we can understand there is this concept of rapid response team development, but may not be well known and may not be as effective as we wanted. So this session may help in strengthening that, right? So at least the providers, as Dr. Jonathan said, any health professionals with a special training to handle critically ill patient or their deterioration. Okay. So apart from health professionals,